Welcome, welcome tonight. I'm so excited to have you with us. Tonight, we are dealing with preventative healthcare in Black communities. And this is part of our Family Life series. In Family Life, we deal with matters that are very pertinent to us. And tonight, I'm so excited to have our guest speaker. Dr. John Cabo is an emergency room physician practicing at Halton Health, which comprises of Oakville, Trafalgar, and Milton District Hospitals. He also practices at Toronto East Health Network, which was formerly called Michael Garron Hospital. Dr. Cabo has been practicing for over 20 years. That shows the level of experience. And he is a passionate educator. Dr. Cabo is an assistant professor of emergency medicine in Northern Ontario School of Medicine, NOSM. Concurrently, he is also an adjunct assistant professor at McMaster University. He is the director of clinical teaching unit in Milton District Emergency Department. Dr. Cabo is a Canadian board certified in family medicine and emergency medicine. He has won awards of excellence in teaching in both McMaster and NOSM. It is our great pleasure to welcome tonight Dr. John Cabo. Welcome, Doc.
Thank you very much. And thank you all for having me.
Well, we have been waiting for this day for over a year. And we know you're a busy man, so it is such an honor to have you with us tonight, speaking on preventative healthcare in our Black communities. We have challenges as a community. And sometimes if we have somebody who looks like us and think like us, it may help us to deal with some of the bottlenecks in the difficulties and the challenges we face as a community. Tonight in preventative care, we want to start from the cradle. No, even the mother's womb. Preconception. Doctor, how do we prevent sicknesses and diseases and illnesses from our mother's womb?
Excellent question, sir. Let us start by saying when a woman is pregnant, obviously the happy days are ahead. And of course, every pregnant woman wants to make sure that the baby is healthy. That's always the goal for every pregnant woman. And of course, we divide pregnancy into trimesters. We should have divided into 3 trimesters. The first 3 months is the first trimester. The second 3 months, the second trimester, and the late 3 months mean the last trimesters. 3, 3, 3 makes 9 months. Now, the first 3 months are actually the critical 3 months, because in the first 3 months, it's when we have something we call in medicine organogenesis. That's when the baby's organs developed. For example, we're looking at the baby's brain development and certain features that are very, very important within that early stage. And that usually tends to occur mainly around 3 to 8 weeks. So by the time you know you're pregnant, remember your baby's brain is developed. And that's where the issue comes in. And that is when you have to make decisions quite ahead. Now, if you are really planning to be pregnant, and then of course you can plan it very well. There are certain disorders that you could help yourself and so on prevent to the baby. As I said, organogenesis, that's when the baby's, for example, organs develop, occur within the first 3 to 8 weeks of pregnancy. So by the time you go to your doctor, your pregnancy test is positive, but how many weeks you're 4 weeks, 5 weeks, your baby's brain is developing. So one of the disorders that is sometimes quite painful, and there's some things that we can do about it, is something we call in medicine, the medical jargon called neurotube defect. And you can sort of say things like spina bifida. For example, you said you have your baby is born with maybe hair, a tuft of hair in the back, or some kind of abnormality in the brain development. Now, there's something, and it's usually a woman just taking the usual medications that most pregnant women are familiar with, so-called Metana. And these Metana supplements are just folic acid in a nutshell. They may have a little bit of iron in them, but basically folic acid. Folic acid is being shown to help decrease the incidence of this neurotube defect. So in other words, taking this medication even 3 months before you become pregnant, start taking them 3 months earlier before you become pregnant, so that you can help yourself prevent your baby, or at least decrease the incidence of your baby developing this neurotube defect. That is one thing that we can really do something about in terms of one. Now, the other thing is that, yes.
One question. Just simple folic acid?
Excellent question, sir. Now, again, you're asking very, very good questions. Now, folic acid comes in, the over-the-counter folic acid comes in, like, we're talking about 0.4 milligram. But if you're a woman who is at high risk, say, for example, you're older, say you're over the age of 35, or you have a family history, maybe someone in your family had a baby that has deformities with neurotube defects like spina bifida and so on. And you can actually take a higher dose, which is usually 5 milligrams, for example, recommended. And that's something that you'll get a prescription from your family physician, because these pills are not small. They are huge, big pills. Obviously, our lovely women knows about those pills, because that's something when you get to your family doctor, they always tell you right away, to go ahead and take your Metana supplement. But the danger is that, remember, by the time you start taking these pills, the baby is already developed. So it's always very important to start them at least usually 3 months even before you want to become pregnant. But yes, it's very important. The dosage itself is a key important issue. The older you are, you may require higher dose, but particularly if you have more risk factors, for example, which your family doctor will usually walk you through. Okay. Now, that's one part. That's the first half of the pregnancy. But also the first half of the pregnancy is where a lot of issues can occur. Just think of that. If you're a mama, you were smoking cigarettes or you were drinking alcohol, by the time you knew you were pregnant, you said, oh boy, I'm pregnant, now I'm going to stop drinking. But your baby's brain is damaged.
Whoa.
So it's very important to sort of look into that. Things like alcohol is something we call fetal alcohol syndrome. Or whereby the baby will born with sort of certain face deformities, but then this baby will have learning disability. They have trouble learning. They have this cognitive decline, something with their memory and so on. They have trouble in school, when it could be prevented just from mama not drinking during pregnancy. But unfortunately, and this is one of the key issues, if you really want to plan pregnancy very well, it's something that you got to think, I'm going to have to cut on my drinking and so on. We all know that there's no safe amount of alcohol that is safe in pregnancy. That is what we advise. So you better as well abstain as opposed to, drink. Now, cigarettes, similarly, cigarette smoking, for example, and there's certain toxins which we screen for. Cigarette smoking, again, can also cause low birth weight, for example. And this is something we call in medicine IUGR. For example, you hear about all these fancy viruses, things like the Zika virus, for example. We said, don't travel somewhere, don't get exposed to Zika, because you may have a baby who has that microcephaly, the small head. And these are all things that comes in terms of how the baby develops, because organogenesis, the baby's development occur within the first 3 to 8 weeks in that first trimester. That first 12 weeks, particularly the first 3 to 8 weeks, that's when the baby develops. And that brain doesn't develop very well if you get exposed to these toxins. Your family doctor will do something we call a prenatal screening. And this is why it's so important to see your family doctor. Your family doctor will do a bunch of blood tests when you tell them you're pregnant. It's happy, good news, but then they'll screen you for a lot of things that can help later on to prevent the baby from getting into trouble. They screen the mama for HIV, because if mama is HIV positive, the mama can be given medications that will prevent the baby from getting the HIV from mama. Similarly, if mommy tested positive for syphilis, medication can be given to the mom so that the baby cannot end up developing syphilis. Similarly, one of the key things that I noticed that notoriously in our communities, particularly those of us, by the way, I'm originally from Sierra Leone, um, little West
Way to go,
Africa.
Sierra Leone.
Right. And, and we have a whole lot of folks there with hepatitis B. And this is not by choice. Hepatitis B, because when you go to the hospital, they're sharing needles, you end up getting blood transfusion. The needles are not sterilized very well. And then you end up having your hepatitis B, chronic hepatitis B. You don't know about it until you end up, when you go to your doctor when you're pregnant, because it's part of the screening test that we do. Remember, we're in one of the best countries in the world where preventive care is high on number one.
That's right.
So when you go to your family doctor, automatically your family doctor will do this testing. For example, your family doctor will test you for hepatitis B. And if the mom is positive, we can also give something to the baby as soon as baby is born to prevent your baby from getting it. So clearly, those are all things that the family doctor will do. So in other words, when you get pregnant, follow up with your physician. There are certain investigations that they can do to screen for a lot more other things and so on. I don't think we have time to go through all those details, but that's the first half of the pregnancy, which I think one of the key most important things. Let us don't smoke. Let us avoid the drugs. Let us don't drink when we want to get healthy babies. And you're looking at a few more other things and so on. Let us take those folic acid pills and so on, particularly in the setting and so on. And if you have a chronic illness, for example, if you have pre-existing chronic illness, for example, you have high blood pressure or you have diabetes before you became pregnant, you got to make sure that your sugars are well controlled, aggressive control of your sugars, when you know that you're planning pregnancy, to ensure that you don't end up developing those complications that can occur within that first half of the pregnancy when the baby develops. Now, apart from that, the beautiful part is that once the pregnancy goes beyond the first 12 weeks, when it hits the second trimester, that's the next 3 months after the first 3 months, it's usually a lovely ride, except that obviously in the first half, we all know very well, our lovely ladies will be so nauseated and the puking can come around. So some of the things that I usually tell the folks, I said, look, guys, you have to step up, don't let them go to the kitchen because they have to avoid all those cooking odors and so on. All these cooking odors, all of those things and so on will just make them the nausea because of the hormones that built up so fastly. But as they hit the second trimester, they're going down to the third half of the pregnancy, things start to slow down for them. But yet also more things develop. Now the baby getting bigger. And of course, most of our women, unfortunately, have other anatomical problems, things like fibroids that puts pressure into the womb and so on, causing them a little bit of a problem again with the baby. So really that support becomes a big issue. And as you know very well, that one of the key things that we notice that occur a lot within our communities, and let me not say only our communities, it's something that I see as well among, my practice setting. And of course, as you mentioned correctly, I've been practicing emergency medicine in Canada over 20 years. And of course, and there's a lot that I have seen. And one of the key things that I notice is that usually in pregnancy, we tend to see a lot of spousal abuse, and this is where the issues comes in. And women usually don't tend to, talk because clearly, as you know, of course, most of our women, are so devoted to family. It's very, very difficult for them to say, hey, look, I'm going to let go. And this is one of the key things. It's very important to talk to someone, for example, talk to your pastor, talk to someone that is very close to you, because when you hold those things can lead to problems, because in the later parts, it can develop something we call postpartum depression, and that can kick in very big time and so on, usually within the first 6 after you have your baby. And then of course, all the stress and all the hormonal changes and all what you compiled all together without talking to somebody becomes a big disaster later on, whereby, it becomes even a risk for your own baby later after the baby is born. So it's important that when you start to feel those kind of issues, make sure you talk to someone. Now, so following up is very important. Again, we are in a society here where healthcare is free. And of course, you just have to make sure you follow up with your physician. There are dating ultrasounds that you get to do. You get to go through a whole lot of stepwise and so on in terms of the second half. Your doctor will guide you when you come to see them next, when they check certain things, when they check your baby into, the anatomical ultrasound about 18 to 22 weeks, they check your baby, make sure the baby is okay. And, there are a whole lot of investigations, preventive care that we do. Things like we screen for Down syndrome much more earlier. Nowadays we have a whole lot, for folks who can afford it, they go to something directly we call NIPT test, which are non-invasive prenatal testing. You go right away, go to DNA, check to the baby, know what kind of baby you're going to have in terms of in general. But look, the question here is that Those are very expensive. And of course, our government makes life so easy for us because of it's free. You start with simple tests that we call the IPS, which is the integrated prenatal screening test. This is all which our pregnant women goes through. So on the first half of your pregnancy, your doctor will do a battery of tests, including an ultrasound of the baby's neck to screen for Down syndrome or these chromosome anomalies. And of course, these things can be picked up much more earlier and give you the choice in terms of what you need, what you would like to do, in knowing that you're going to have a baby that's going to be a problem if the baby does come out. And there's a whole lot of planning that comes within you yourself and your doctor. So following up is something that I noticed that we don't like following up. And again, the reason why most of us in our community we don't like following up with doctors, it's not because we don't like the doctors, but you are the breadwinner. The time that you have to go to work, you have to go this and so on. It is hard. It is hard to get that particular time and so on to be able to go to see the doctor. But remember that, not seeing the doctor will be a whole lot of problems, particularly when you're pregnant. Pregnancy is not the time to say you're not going to see your doctor, particularly when those particular testing are important to be done. Now, I just want to say one more thing just for the last half of the pregnancy so that I can leave pregnancy alone. The last half of the pregnancy, the last 3 months of the pregnancy, basically that's when the placenta takes over. That's after 20 weeks of pregnancy. So up to 20 weeks of pregnancy, there's very little doctors can do other than the whole hurdle is you up to 20 weeks of pregnancy. Because if you're going to have a bleeding, you're going to lose your baby, nothing we can do because the baby is not viable. And that's why we use the word abortion. If anything happens less than 20 weeks, we call it an abortion because there's very little we can do. And when that happens, when you call an ambulance or get to see anybody, you're going to be coming to see us in the emergency department because your baby, obviously, we hope, or we always, all of us hope that everything is okay. When we put in our hand, check through the ultrasound, we want to give you the good news, but there's nothing we can do if things goes wrong, within the first 20 weeks of pregnancy. After 20 weeks of pregnancy, particularly after 24 weeks of pregnancy, that's when we have that viability. And that's when you are in one of the best countries in the world, whereby if something goes wrong after 24, 25 weeks, the likelihood that you're going to get that baby is so higher than not, and then of course, and that means that there are any complications that occur later in pregnancy, you're going to go to a special unit. We call them the obstetrics unit. So even if you call an ambulance, don't be worried that you're going to be sent to the emergency department to see an emergency doctor first. No, if you're 24, 25 weeks, you call an ambulance, they're going to send you right to labor and delivery. Much more aggressive setting where they will ensure that they take care of your baby accordingly. And I'm not going to dig into all these other things, for example, that can occur in the later half of pregnancy. Things like something we call preeclampsia in medicine. That's a medical jargon, meaning basically toxemia. And toxemia is the word itself, toxemia, is something that, when you hear it, toxins. And, some people call it that high blood pressure. I end up getting high blood pressure in the later half of my pregnancy. And this is something that we see in our Black community. And it's obviously here for us in North America, this is something that is managed quite well. But still lack of follow-up causes so much problems. I'll give you, for example, an example. Within the last 2 years, I saw a lady in the emergency department who did not follow up with a physician for a long period of time. And she has high blood pressure. And then I saw her in the emergency department, and of course, her baby at that time is already dead, and that was at 24 weeks. Now, something we call toxemia is something that is very significant. So high blood pressure, when you get high blood pressure in the later half of your pregnancy, after 20 weeks, we use the word toxemia because when the blood pressure goes up, remember that you share one thing with the baby, the placenta. The baby's blood flow, the baby gets from you, from the placenta. That's where you share one thing. You have the baby part, you have your part from the placenta. So if you have high blood pressure, your blood pressure is very high. The baby, that blood pressure decreases the blood flow to the baby. So the baby will not get enough blood flow. So your baby starts to shrink and shrink and shrink, what we call growth retardation. They retard, they lose weight, and they die. Wow. So that's a very, very important thing. That is why following up with your physician, checking the baby, it's very, 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 very important. And toxemia can occur in people who do not know they have high blood pressure until after 20 weeks. That's usually when that can occur. And hence, of course, it's very important to ensure that you follow up with your family physician. Of course, in Canada, that is done almost every 2 weeks at least. Usually after 28 weeks of pregnancy, you're brought in to see your family doctor much more often than the usual once a month. Once you hit after 28 weeks, we bring you more often because we want to look for these things. We check your blood pressure all the time to make sure that you don't develop these complications that will help, for example, prevent the baby. So following up is one of the key things that I'll stress on that part.
Wow, this is amazing. Now, in our mother's womb, we can prevent some of these diseases, as you've just told us. What about neonate to 1 year? The child has been born. The child is here. Everything looks okay. How can I prevent diseases and sicknesses up to the age of 1?
Wow, another excellent question. And actually, we sort of we divide this usually into, we use the word neonate. The neonate means the first 1 month of life. And then we use the word an infant. And when we say an infant, we're talking about literally from 1 month to 1 year, an infant. But the first 1 month of life is the neonate. And neonate, the most common cause of death in a neonate is actually things, the genetic defect, things like chromosome anomalies, things like they were born with. That's for neonate, for newborn to just die. And we take it serious. If a newborn dies in Canada, it's a whole lot of big issues. It's not like just because we have very excellent preventive care, thorough and so on. There's a whole lot of coronary issues and so on. There's a lot of inquest that goes into that to try to ensure that this is prevented in the future. Now, so the neonate itself, thinking that this is chromosome anomalies, we think it's usually congenital anomalies. And that is why in terms of, so anything that occurs in your newborn, if you have a baby that is less than 1 month of age, a problem goes wrong, you need to see a doctor. You can't guess. You cannot guess. If you have your neonate, for example, you say a kid like, for example, you said, you know what, my 2 weeks old is not feeding all day today. Should I wait tomorrow? No, tomorrow. Today I see the doctor. Because
Right.
that 2-month-old that was sucking very well, now not feeding, that 2 weeks old may have an infection that is walking through their body that kills so fast. We call sepsis, Right. Or that 2-week-old may have some kind of abnormalities in their chromosome. As I said, the most common cause of death is congenital anomalies. There could be some defect that's remained undiagnosed. As I said, of course, most of the diagnoses that occur congenitally, we are in one of the best countries in the world, right in utero. When you come in, as soon as the baby is born, the baby get a battery of genetic testing right away, to sort of screen for these things and so on. So it's something that we screen for. But there are some of them that present later, despite we're doing all our screening. So within the first 1 month, less than 1 month of age, your baby is sick, you got to see a doctor. That's a no-brainer on that part. That should be very, very important. Now, so from 1 month of age to the age of 1 year is where a whole lot of issues comes in. And one of the key things that comes in from 1 month to 1 year, if you ask yourself, you said, what is the most common cause of death? What are the things that can kill kids from the age of 1 month to the age of 1 year? But there's something we call SIDS. We call it sudden infant death syndrome.
Right.
Why would an infant? Remember I said earlier on that an infant is from the age of 1 month to the age of 1 year, an infant. So why would an infant die suddenly? What went wrong? There's something we call SIDS, and SIDS has been studied a lot. And we use the word SIDS because we can't find a cause.
Right.
Sudden infant death syndrome, that you can't find a cause, because if it's the heart, or there was an accident, or somebody abused the child, or those kind of things, you can figure that out. But sometimes we do all our testing, we can't figure it out. And so we think, so what is causing SIDS? Is there anything we can do to prevent sudden infant death syndrome? And there's a whole lot of studies on this that try to help us as doctors what we can do. And one of the key things that we found that in terms of, it says a whole little thing in terms of, so when the baby lies in the crib, because mom will say, what, my baby was okay. I left the baby lying in the crib. I woke up in the morning, the baby's dead. So mommy is so scared. Mommy is obviously, there's all of these cops and everybody in front of mommy. Mommy said to you, mommy said, I didn't do nothing bad. But then mommy go back, mommy start to think, what could I have done better? Always, what could I have done better? So there are certain things, think of it, why would that kid die? So the studies have said that if you have, for example, stuffed animals, when the baby is born, everybody give your baby all kind of animals, all kind of all these gifts and so on. Yeah. And you have all those gifts, you put them all in the baby's cribs. No. Babies should not sleep with stuffed animals. Because if that baby, remember that 4-month-old, that 5-month-old, that 6-month-old, their ants are like brittle like that. They just go, and then they cover their face and then boom, they choke. You
That's
know,
very interesting because it's very common to see all these stuffed animal in people's cribs and all that stuff. So you advise strongly we shouldn't do that.
at night. They should not sleep with those things. Not when during the day. This is one of the key things that we normally say during the day when mama is there watching the baby playing. Yes, that's even when the baby's playing. We said, you know what? We say lie front to play, lie your baby front to play. The baby love their belly out, but at night to sleep back to sleep, but
What
front
if
to
the
play.
child is not sleeping
You
and
know,
crying?
and and that's mama is still there, and that's one of the key things. Mama is there. As long as mama is there, that's one of the key most important. The problem is when mama start to take all those toys or all those clothing. Remember, these kids have the ants grab off. The kids will choke with those things, and this
Wow.
choking is what will kill the kid. Mama will be sleeping, and then boom, and then of course those sort of it's just simplest thing and so on. Now, some mommy says, can I give them maybe a pacifier, for example, if the baby is crying?
Yes.
Well, actually, studies have shown that pacifier, actually, I'm not recommending that give your baby a pacifier, but pacifier actually are safe. Actually, they prevent SIDS. I'm not saying that give your baby a pacifier, but if your baby has a pacifier, that's fine. There's no trouble behind pacifiers. A pacifier, obviously, actually prevents SIDS as opposed to anything. Let me not say prevent, but protective against SIDS, because is in the mouth and so on. Now, so if you have, for example, as you mentioned, just to answer your question, the baby is crying, for example, some of these kids looking for mommy's breast, maybe they just breastfed recently, a little bit of a pacifier, and so on, and talk to them. That could help in terms of calming the kid down and so on. But try to avoid medications. There's a lot of medication that have sedative in them. Don't give your kiddie Benadryl. Benadryl has no role in kiddies. It says, I'm going to give my baby sleep easy to sleep. Well, the sleep easy, and then your baby's brain can't tolerate it. The sleep easy, you wake up in the night, in the morning, your baby is no more there. It's just a tough call. And then here you have, for the rest of your life, this is haunting you. And then, of course, the cops will be haunting you too. So it's a whole lot of process and so on that you got to go through and so on. That, in a nutshell, again, anything that we can do to prevent SIDS. So front to play, back to sleep. During the day when the kid is playing, get them play on their belly. They love that. But at night, let them lay on their back. Don't lay your baby front to sleep. They choke.
Wow.
Now, the other thing also that you also have to look for is things like simple stuff and so on. Well, you know what? If daddy smokes, tell daddy, I know you love, little Johnny. Little Johnny's not going to do well when he smoke. Why not at least, okay, maybe it's, smoke outside, but daddy, oh, well, I smoke outside. Well, you smoke outside, but when you came in, you're going to rush when you just come from work, you have all the cigarettes on your clothing, and then little Johnny is going to come to daddy. And then little Johnny, boom, all that cigarette into little Johnny's nose, and then cold symptoms. Cold, ear infections, and more ear infections, more antibiotics. The cycle goes along. And then all those antibiotics are going to suppress little Johnny's system when little Johnny really does not need those antibiotics. All what little Johnny needs to know is that, daddy, please don't smoke. When you're going to play with me, maybe daddy, remove all your clothing first, go shower after you smoke, and then come play with me. So there's a way in terms of ways that we can do stuff to try to just help in terms of preventing these recurrent infections. So SIDS is one thing, but another very important that I want to say within that 1 month to 1 year, and again, thanks that we're in sort of an excellent country, is vaccination. It's just so much in terms of, if, vaccines in Canada start at the age of 2 months. And then, of course, you have, series of vaccines that we give. I'm not going to go through all those vaccines, but one of the key things that I have to say is they all targeted to prevent these infections. If your kid has all their series of vaccines, if you notice that studies over a year, I've been doing this for 20 years, and new vaccines are just developing. I can tell you for sure that about 22 years ago, almost when I started practicing, we did not have a sort of what we call Preventative, the pneumovax, the pneumonia vaccine. But because the government is so smart, they noticed that, yes, there's a lot of kids that are getting a lot of ear infections that is caused by this bug that's called strep pneumonia. It's not too long. Over the last 10 years, we have another vaccine added to the cocktail of vaccines that will help prevent that invasive infection. So getting your kid vaccinated is a no-brainer. It's just so much important. There's, again, I'm not here to talk about in terms of folks that are against vaccines or anything like that. my goal here is obviously, I'm so happy that you give me this opportunity, Reverend Pastor. This is, something that I've done throughout my career. I spend a lot of time helping, our colleagues, international medical graduates, and so on, to ensure that they're able to get a license in Canada.
God bless you.
And of course, and one of the key things that I'm passionate is about is really education, helping not only in terms of within the community where we're in, helping Canadians, as they help us to be part of their society, but of course helping some of our folks that do not have sort of the level of education that we have, for example, to be able to assist them, at least to give them an insight into these issues. But look, in terms of saying that things like people who are afraid to say, oh, vaccine will cause autism and so on, so therefore I'm not going to give my kid a vaccine, when there is no evidence, so I don't go into those, but there's really lack of evidence. I'm somebody, as you all know, that you probably heard about McMaster and evidence-based medicine and Nozom, there's a lot of research and so on. So anything that we touch on, so there's clear evidence. You have to have that evidence. And so not just somebody say, we use the word myths, M-Y-T-H. There's so much myths out there about anything. But think of it. If you're saying that something is bad, how many millions of us that have vaccines, we're all perfectly healthy. You're looking at 1 or 2 people that have issues which may not be related to the vaccines. But then, of course, you don't utilize that to target your kid, for example, not getting vaccinated, when you can protect your kid and so on with some of these notorious infections. I can tell you for sure, when you come to me in the hospital, you said if your child has fever, for example, less than the age of 1 month, they don't go home. Because remember I said less than 1 month, it's a problem. Less than 1 month, you come to the hospital, don't expect to go home, particularly if it's a fever. You're going to be admitted. But after the age of 4 months, 6 months, now remember, you already have 2 vaccines. You've had the 2-month vaccine and the 4-month vaccine. So you come into me like your 6-month-old, your 8-month-old with fever, my chances of suspicious of something terrible, it's less. Because now I'm starting to think that because you have the vaccines, you're protected. Now I'm trying to think about that, if I can't find a source, it's likely that this potentially could be a virus. So there's a whole lot of panel of thoughts that we have. So vaccination, that is why all the doctors always ask about those issues in terms of vaccination, for example. So for the 1 month to 1 year, the key things here that I just to highlight again, once again, it's basically protect your kids from preventing them from getting SIDS in terms of, look at that crib where you put your baby. Did you check it very well before you go to bed? Did you make sure that the kid is not going to grab anything easily that they can choke with? Is your baby lying supine to sleep and not prone, that they could potentially choke? Does your baby has a cold with a stuffy nose? Did you clean the nostrils? So there's a whole lot of issues that you should think about in terms of before you put your baby to bed and so on to prevent those. And finally, ensure that your baby is fully vaccinated and, talk to the partner, whoever smokes, not just the guy. What about if mama smokes? It's a whole lot of a pattern over down there, because that's one of the culprits behind most of the common colds that we see within those age groups. Okay.
Wow, this is amazing. This is a load of information. I hope you are getting your questions ready for the doctor, because once the doctor goes, I'm not answering any questions. But we're going to go for a short break. We'll be back. And when we come back, we're going to talk about the school-age children and teenagers, how to prevent sicknesses and diseases. It's been an amazing time. Stay tuned. Don't go away. Call a friend to join in. This will be great information for you. See you soon. Welcome, welcome back. I think we can start writing books. Well, we were with Dr. John Cabo, an emergency room physician, and he's speaking to us on preventative medicine in the Black communities. And this also affects every community as well. We're now going to talk about how to prevent sicknesses and diseases in school-age children, that's 6 to 12, and also teenagers. How do we do that, doctor?
Wow, that's another great question. Now, let's start with school-age children. And again, one of the key ways when you think about preventive care, as researchers, the first thing that you think about, what could potentially go wrong at this age? What will kill these guys? What can you do to prevent death, we call mortality? What could you do to prevent sickness, mobility? So it's a whole lot of issues. But the key thing that you think about when you start to think about those, particularly things like, I'm going to leave teenagers on the side here. Let me leave teenagers as a whole gang. But overall, when you think about the young, the most common cause of death is usually accidents. And then there's a whole lot of things and so on that we can do to prevent accidents. You start with some of the basic things that you do as a parent, things that you can do. Say when you purchase your lovely vehicle, make sure that you think in your mind the ages of your children and which one of them that needs a booster seat, which one of them that needs, sort of the child safety seats and so on, whether or not they need a holster and so on, or whether or not this kiddie, is less than 13 years of age, for example, they have to be at the back seat, not the front seat. I want to go close to daddy in front, So there's a whole lot of these issues first that you have to think about. Because one of the key danger is that imagine your kid, and sometimes it's hard because, for example, I can tell you for sure that roughly it was about 4 years ago, I was back home, and then when you pass by, you see folks in the cab, like you have 5 or 6 people sitting in the car, nobody with seat belts, and as an emergency room doctor, it's unbelievable. Trauma, of course, that's very common, and it's the most common cause of death in the young. So. Healthy Johnny, one day, boom, he's gone. Why? Because of that simple mistake for not wearing a seatbelt or for not using the booster seat that he needs. Because little Johnny says, no, daddy, I'm going to go to the front seat. I'm old enough. Well, you got to sit in front. You got to get to 13, man. We're close there yet. Back. You're less than 13, go to the back, but also there are certain sort of, so some of these newer vehicles can tolerate in terms of when to move your kid from a car seat to a booster. Of course, the usual 40 pounds rule doesn't work for most of these newer generation vehicles. Right. So you can talk to the vehicle manufacturer, and they will give you sort of the limit in terms of when and so on. And that's one of the key things that you can do when you purchase a vehicle, to ensure that you know exactly when your child is going to be moved from this and this, to make sure that the airbags are protected. And this is one thing that can happen. A few years back, it took me almost 2 days to sort of think about a little kid that died of an accident. We as emergency room doctors, we resuscitate. So, you come in dead, we still think that, no, we can save you. So we do all what we could. Although you're dead, we work everything that's possible to try to save a life. But we obviously all hoping that, if God has mentioned that your life is still going to be there, most of the time this works. We do all what we could. But in that sense, when we go home, we carry that with us. What can we have done to save this life? When it's a simple thing that he can do, I said, if that kid was only wearing that seatbelt, you got to go back and think again. And that's one of the key things. There's nothing you can do, because if you want to sit where daddy sits, because look, remember that daddy is tall enough, daddy's weight is big enough that the seatbelt is meant for daddy. And you are small. That seat lap goes right through your neck. So when the brakes hit suddenly, zip, and then you're gone. That movement, our body is not so, that movement, that quick brakes and so on, that flexion extension can either lead you to paralysis, slashing down your cord, or can literally cause multiple injuries, including the head, the torso, and so on. Chest injuries that can kill instantly, and of course, belly injuries. So it's just important to ensure that we know exactly when to use the tool, when do we move from a child seat to a booster seat and so on to a holster? And of course, at what age, particularly based on the manufacture of these new vehicles. Most of us, even as emergency docs, we're losing track of these new vehicles. So much safety nets that they have in place that, you can actually, it's amazing how much weight they can even tolerate, than what the evidence says. So it's always very important to look at that. So that's one thing. One of the key things right away from safety is ensuring that you prevent those. And having said that too, accidents include poisoning. Simple things that you can do for your kid. Remember that kids have the mouth period where everything goes into the mouth. But at the same time, they are kids. If you putting up a little bit of small, tiny things, for example, peanuts, sardine, and peanuts are too small. If that kid swallow that peanut or that peanut goes the wrong way, it went through the windpipe, bam, that could be a problem. So it's very important. And when your kid is playing, watch the surroundings where your kids are playing. If they're playing with certain seeds or small foods that they can swallow, they can easily inhale, take them away. Watch your kids. And poisoning, make sure that the cabinets, when you have a child, they can go anywhere, particularly toddlers. And with the key ways you can help yourself to actually prevent toddlers from getting into all these poisons is carry cabinets, safety cabinets, locked drugs, and so on. And one pill of grandma's medication kills a little kitty.
Wow.
It's just so much important to ensure that those are all locked together. And these are the minor things that you can do. Other things, again, as I said, it's very little. Most common cause of sort of even fever at that age group, as we're just talking about, for example, for the school age children, it's usually cold that they pick up as they start to go to school. Cold symptoms, very, very common. And one of the big mistakes that we do is that, our kid has temperature today. Little John is warm, mom is worried because little John is warm, and little John is going to be shouting to mommy, and mommy is worried. Mommy thinks that the big gong is going to save this kid. Mommy is going to go for that antibiotics. And because we have that preset thinks that every fever needs an antibiotic. And that's not so. Most infections are viruses. Remember in those old days when it was actually when somebody gets sick, you're happy when they get fever because they burn the infection out. In the old days, but nowadays, no. You get fever, but you got to go see the doctor. Well, when you go to the doctor, I can tell you for sure. Obviously, some doctors that clearly, have a lot in their plate. They have to see a lot of patients and so on. If you're a demanding parent, well, the easiest way for me to get rid of fear, it's bad medicine. But if I give you what you want, which is the antibiotic, you go home happy. You go home happy. You're gonna destroy your kid's life with that antibiotic that your kid doesn't need. So one of the key things that I have to say is that do stuff to prevent. Do not rush if your kid is otherwise well. Having said that, anytime your kid is sick, you, a parent, know that your kid is sick, completely sick. If they are sick, get them to see a doctor. That's no brainer. And again, another thing that can also help you, there's a line called Telehealth Ontario. Telehealth Ontario is available to all of you. It's just you call them Telehealth Ontario. They can tell you whether you call 911 or you call an ambulance or stay home, see your doctor. They will give you an advice because most of the time that we have fear in the Black communities that we don't like to, we appreciate a lot what Canada has given us, and we don't like to use the system. And that's one of the key things. We don't like to go see a doctor because the government is paying for it. We kind of fear that we don't want to use them. We can manage things at home. So, and also we don't want to call an ambulance because, somebody else is going to pay for it. We don't want that. If you are the parent, you're going to pay. If you're in Africa, you're going to pay your money. You take them to the hospital. You're going to see the doctor because you have the money. But here, you're afraid that somebody is going to pay for you. You don't want that, which is good. It's a kind of the unique qualities that we have. But then, but you're also afraid that your child may be sick. You don't know who to call. Call telehealth. Telehealth may be a transition point because they will advise you if you to stay home.
Free. Doctor, that one is free?
Yes, sir. It's free. Yes, Telehealth Ontario is free. Yeah.
Okay.
Yeah. And also, for example, say even if your child, for example, suspiciously had swallowed something that you're not sure. Say even if you think that, okay, that's Tylenol they have swallowed, you have a pill they swallow, call poison control. We got poison control. Just call poison control. Just Google poison control. Canada, the number is there. Call them. They will guide you through. They will tell you whether this requires to go to the hospital or not. And they usually fax something to us to the emergency department. and so on. So I guess the fear is that should you call 911 because nobody wants, oh boy, that's siren that's coming over here and so on to a house. It's just that kind of fear that we have sometimes, usually it sort of causes that issues whereby we tend to see, and look, I've been doing the math, so of course, I spent 6 years working at UHN, that's Toronto General, Toronto Western, before moving, obviously to Halton and North Ontario, for example. Now, so I see a whole lot of difference in terms of the Black community, how we sort of, really one of the, and again, and looking at myself as well, and not only as a physician, but as a parent, looking through exactly what I would have done and what I would have not done and so on, and looking through how my own siblings, for example, manage their own issues, for example. So the key point here is that, yes, we don't want to call 911, but can we call somebody else? You have this route. You have the route, for example, to call Telehealth Ontario for advice. And they will tell you whether you can wait or you have to go to the hospital. And these are well-trained nurses. They have computerized and so on. And look, they're more likely to tell you to go in than not. So they don't risk it at all, those guys. They're very thorough, And sometimes when we see you guys in the emergency department, you said, oh, telehealth send us, sometimes we kind of say, okay, telehealth, but the bottom line is that, we take them very serious. Because I can tell you for sure, they've sent a lot of serious folks to us and so on. And what we see is just the ones that they send. There's a lot more that they don't send to us. They will advise you appropriately. Minor things that you can actually use to help your own child at home, rather than actually having to come to the hospital. Now, let's hit the teenagers. The teenagers is one thing. One of the key, most important thing that we have with teenagers, actually, we have, there's something in medical education that we use in part of family medicine or emergency medicine residency programs. It's something that, a mnemonic that we memorize, we call it head screen. That's a medical jargon. It's just a minute for us to remember the questions that we bang teenagers. And that we ask them about their home environment. We ask them how is their eating habits and so on. We ask them about their friends, so on. How is their mood? Are they bullied at school, bullied at home? Abuse. These are things that notoriously we bug them about. We ask them about drugs and alcohol, because this is the kind of the age where you can really transition. And this is where really the beauty of religion comes into power. For example, because one thing that you notice that when a teenager that follows their parents from day one, they grow up with religion and so on. Some of us, for example, you see things lapse. As you see, for example, you watch through, your children, for example, grow up. You wonder, you said, okay, what about if this was a different, if they grew up in this setting, maybe I would have changed something, But you don't wait until they are up there. Right from the get-go, when they are at that preschool, that's when you attach to your kiddies. When they're at preschool, you attach to your kiddies and so on to try to prevent, because when that bonding starts, they follow your path. And for example, you take them up with you, when you go along and so on, they follow your path and so on. And that sort of bonding will take them a long way. And then, of course, they will also be able to share, their bullying stories with you. And then you can work things together, for example, as parents. But, clearly, there's a whole lot of issues with all these mental illnesses that sort of kick in within our teenagers, but all these drugs and alcohol that sets in that particular period of time in the teenager's life. Of course, all what we do as clinicians, we screen for these things. So if for example, your child comes to me asking for the birth control pill, technically as a physician, it's a privacy, Unless, of course, she's less than 16 years of age, that might not be a great idea. If she's 15 or 14, that will be tough. It depends on, I'm going to ask exactly, hey, who is this guy? If this guy is going to be like a 30-something-year-old that's trying to get a 15, no, that's abuse. That's not an issue. But in an older child, for example, who is clearly independent, your baby could be being on medication, you don't know about it. So the only way you can know is by you sharing with your baby. Sharing with your little girl, talking to your little girl, your 18-year-old, 19-year-old, maybe taken back, because we don't tell you. Because we're not allowed to do so as physicians. And there's no point for us doing so, because that kid needs their independence. They have their right. They have their own independence for them, because otherwise they won't protect themselves accordingly. And then, of course, the result may not be even greater. So teenage life is where you think about all these issues. So you think about how is the home environment? How can you prevent issues? Create that home environment for your kids right from the preschool. Don't make the errors that most of us make, for example, because as professionals, not only that we spend years of studying, day and day studying and teaching and so on, you forgot that you have a little kitty at home that's looking for daddy's nurture, that looking for daddy's time and so on, or that's looking for mama's time. Because why? Because, hey, daddy is thinking of not only you, daddy is a little African. Daddy has mama, that is out there back home. Daddy has the brother that doesn't have nothing.
Waiting for the money.
Yes. so they're waiting for the money. So obviously, if daddy spends that little time with you, and there's no time, to get to work, and then of course, grandma may not live that long. So there's a whole lot of issues that faces us, within our own community, that we have to find ways and means for our children. I'll tell you for sure, our children will understand if right from the beginning we involve them. If right from the beginning we involve them, and the kids will understand it, and they will actually be more than happy to help you out. But you got to involve them. Don't take all the burden. Let them involve. Let them involve what you are going through. And then participate and so on. There's some way you can organize. You can still participate, in their lives and so on, to prevent most of these issues that occur with teenagers. And of course, then they become lonely, away from you. And then, well, there's somebody else they're going to have, that friend, that is the drug dealer, that they're going to have a friend with. And then, that friend, and that's this high in this, and this is notoriously bad. Cocaine, for example, one single dose of cocaine can cause vasoconstriction, cause a heart attack and death. It can cause a stroke and death. One single. You just snort that bump. So you're lucky if you survive. So why risk medication? Why risk a drug? When you take those medications, they disturb the chemicals of the brain. These chemicals, we call them neurotransmitters. There's many of them. So of course, when you take your cocaine, it's not, it works instantly. So you feel high. You have that euphoric feeling. But that euphoric feeling comes in with that neurotransmitter. What it does, it's a stimulant. And it blocks the blood flow to your heart. And then it can cause a heart attack, or it can cause a stroke. There's so much dangers behind these drugs, but yet, particularly at the beginning, the problem is that once you don't stop it from the beginning, you encourage and it continues, bam, and then the brain starts to get used to it. Then the addiction kicks in. When the addiction kicks in, it becomes difficult. It becomes difficult because no matter what you try to do, it's always tough. And when a lot of people can afford drug rehab centers, most of our folks cannot afford that. You can afford to go to a drug rehab, sort of to walk you through and so on, to try to help you with those issues, and it's very, very difficult because you come out of the drug, when you come back home and you get stigmatized. When you come home, so your family that's supposed to accept you, they say, oh, you're a drug guy, bye-bye, so you just, again, you push again to the drug side, so the key most important thing is that we have to realize that addiction is a disease. So if you have anyone that is really addicted, for example, it's now, think of, they have a disease, they have something down there that's constantly telling them they need this. So it needs a whole gang of group. And it's one of these key important things. As we take psych histories, we said, tell me about, what is your support system? Who is there? But I can tell you for sure that based on my experience, I can tell you for sure that Black families, we're very, very supportive of each other. We go through to the extremes and so on to try to support each other in many different ways. You can see that our mamas will do everything possible to make sure that we step up there. But again, we also have to, realize the fact that we can put a stop to this. We can put a stop to things and so on by ensuring that, we have, things in place whereby when something goes wrong, which I'm pretty sure probably, having the opportunity with you right now, organizing this for the church, just tells me, obviously, what kind of person you are in terms of the love that you have for the folks that you serve, and I'm almost certain that, there's a whole lot of things that is open for those folks, and that will help them in the future to ensure that those who are suffering through addiction, that there's something in place for them that you will be able to, bring in a group and so on to be able to help them out, if that is not already in place.
That's amazing. Talking about that, your first question is already in, and it's about fibroids. The question is that why is fibroids predominantly in our community? What causes it?
Right. That's an excellent, excellent question. And this is actually, there's a whole lot of issues that have been dealt with in terms of looking into, fibroids itself. Now, a fibroid, it's basically a benign, so it's not cancer. When we say a benign, it's not cancer, it's a growth. It's a benign growth in the uterus. It's a growth that occurs in the womb, in the uterus. Now, the uterus has many different layers. It has many different layers. Like in everything and so on in medicine, there's a different layers, the uterus itself. Now, you have the inner layer of the uterus where the baby sits. You have like the muscle layer. You have some other layers on top of it, many different layers. And these fibroids, these small, tiny, benign growths can grow in any of those layers.
Inside.
Inside, they can grow in any of these layers in the womb. And they cause like the womb to become quite bumpy. The womb becomes quite bumpy because they are bumps, they are growth. They are tumors, you can say, but not cancer. None of them are cancerous. They are benign growth. And there's a whole lot of studies that says, why, look, it's not just occurring in Africans. You see a lot in Asians as well. It also occurs in a lot of Caucasians, but of course it tends to be more occur in our folks and so on. And of course, in the past, when I first looked at this, I said, why is it just in Africans? But when you go through the evidence, it's a whole lot. It's not just us, it's a lot in Caucasians, but of course, yes, a lot in Asians as well. You're looking at it in the fact that when you count almost like you say, at least, if you say all the women that surrounds you, almost everybody of the Africans tend to have fibroids. So what are fibroids? Fibroids are small, tiny, benign, so they're not cancer, growths that develop in the uterus. They tend to be, there's some theory that says they could be influenced by hormones. And that's theory. Really, in terms of the evidence, is not very strong. So therefore, he says, what? When you hit menopause, the fibroids will shrink. So fibroids growth, when you hit menopause, they start to shrink. Because when you go into menopause, your hormone level decreases. The fibroids start to shrink. So there's that theory because that's hormonal theory that says about that in terms of in general. Now, they occur pretty sporadically. Now, these things can grow into golf balls, big golf balls. And when they grow bigger,
how big can they be?
They can be anywhere. You can have like small, tiny ones like a centimeter. You can have like 15 centimeter. You can have like fibroids. You can have multiple fibroids in many different layers of the uterus. So the problem is that our women face a whole lot of problems with these fibroids because the fibroids causes many different symptoms. Imagine you have this benign growth that is big sitting in your womb. It almost feels like you have a baby in your womb. That's pressure. And that pressure can put pressure in your bladder, causes you to have bladder symptoms. You have to go pee all the time, for example. Even if you drink a little bit of water, you have to go pee because of that pressure, that it puts on you. Or if that fibroid is sitting around, there's a small layer, we call them submucosa. It's just a medical jargon. It depends on where they're located. And that area has the blood vessels. So it can cause you to have bleeding, irregular bleeding, many different times. You just bleed. When it's not even your period, you bleed completely irregularly in away from your period, for example, or excessive bleeding. So all of this causes our women so much of a problem and so on. But, the question is that to answer your question, nobody really know exact particular pinpoint cause. They cannot say particular, there's a whole lot of these theories, but there's not a particular pinpoint cause and so on. But so can we do anything to prevent?
Yeah. Can it be prevented?
So can we do anything to prevent them? I'm afraid the answer is no. But what can you do in terms of what can you do in terms of if you have fibroids? Well, look, if you have small tiny fibroids, don't worry about them. You get an ultrasound, somebody tell you have a fibroid that's a centimeter, it's okay, don't worry about them, no big deal. A small tiny, as long as it doesn't cause you symptoms. If you have an ultrasound that says incidentally you have an ultrasound, no. But when they are causing you problems, for example, they're causing you to bleed, there are many options that you have in terms of managing them. And first of all, you have to determine whether you're ready to have babies or not. Because if you're fertile, you want to have babies, there are many treatments that you can use, that you don't necessarily, like, for example, removing the fibroid, something called a myomectomy. Remove the fibroid itself. And there's many procedures, and I can tell you once again, you're in one of the best countries in the world where laparoscopically these fibroids can be taken out quite easily. to enhance, to allow you to become pregnant. And once you have your babies done, there's many ways these fibroids can be dealt with. Once you have your babies, if they cause you bleeding, there are many things they can do. You can cut off the flow to the fibroid, something they call ablation, if you decided not to have your babies anymore. That when you cut off the blood flow, then there's nothing to feed the fibroid, so they shrink because you cut off their blood flow. There are other things that you can do. For example, not just ablation. Particularly if you already have your babies and you're bleeding so much and so on, you decided that you don't want any more babies, and there's other issues and so on. You can get a hysterectomy. There's a whole lot of things down there that are available for treatment, but it's rather unfortunate in terms of the fact that up to this point we can't pinpoint. And we cannot pinpoint. In terms of, I remember you're in one of the countries in the world where research is so much embedded. In terms of, I wish we can pinpoint, and then we could say, hey, take that magic pill to prevent fibroids. No, that's nothing available. Nothing available. But when we do get them, though, there's a whole lot of treatment options that are available, depending on whether or not you have to preserve fertility, or whether or not you've already have your children and so on, and depending on whether you have symptoms or no symptoms. So the management will differ. But again, don't worry about them. They're not cancerous. The only catch is that if you're on menopause, if you're already in menopause and then you see something in your womb that looks like big fibroids when you're already in menopause, long after menopause, that's a bit concerning, because there's something they call leiomyosarcoma, which is a cancer format that looks like fibroid, but that could be cancer. So if you hit menopause for a long time and you see that these big bumps in the uterus, that needs to be dealt with anyway by a gynecologist accordingly. Which obviously they manage very, 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 very well. But I'm afraid there's no magic pill on this.
All right. Now, before we go on our last break, I know there's a question in, but there is this question which came to me privately, which is about erectile dysfunction. Mm-hmm. Is it dangerous, or when you find out that you are not functioning, is there something wrong? Or is there something to prevent this one as well?
Wow, what another excellent question. That's one of those excellent questions. And I'll tell you for sure one thing. When I teach, of course, for those folks who knows me, I'm a passionate teacher. I love to teach, with residents and so on. And one of the key things every year when I prepare students for board exams, I always ask them these questions. I said, what do you think is the most common cause of erectile dysfunction? And it's amazing how majority of the students normally say psychogenic. They think it's the brain. They think psychogenic. That's what most of them thinks. That's not the case. That's not the case. But most of the students that you ask, they think psychogenic. They think that, well, you know what, when we say erectile dysfunction, obviously it's either things don't stand up, or things stand up but they can't do the job, when they stand up, or it falls down quick. So there's many different ways that in terms of way determine that. The question is that, why is it not standing up? What is that? Or why does it not maintain it? The key issues behind that usually it's blood flow. Blood flow. The most important issues is blood flow to, the blood flow. If there's not enough blood flow, that will literally cause erectile dysfunction. That's blood flow to those those erectile tissues. The blood flow has to get there. And what is the key thing that causes the blood flow reduction? Again, similar to what we normally think about. The same thing that decreases blood flow to your brain that causes stroke, the same thing that decreases blood flow to your heart that causes heart attack, is the same thing that decreases blood flow to the guy that causes erectile dysfunction. So if you start to have erectile dysfunction, say, oh boy, the heart attack is on the way.
Oh, wow.
So that means the first thing to attack erectile dysfunction is don't just think about it alone. Think that you may have issues with blockage. You may have flow problem. You go to see your family doctor. Your family doctor will have to check your cholesterol to see if your cholesterol is high. That's caused that blockage. Your family doctor will have to check you for diabetes. Because there's a couple of things that we tend to show the risk factors. We call them risk factors, things that predisposes you. Number one, obviously being African American is a huge risk factor. But you think about it in terms of age, obviously, little kids don't get that problem. But once you reach over the age of 40, those issues start to occur because flow problems can occur. Smoking, if you smoke, smoking causes stasis, decreased blood flow, diabetes, and high blood pressure. We know that high blood pressure, we can screen for it and figure it out. We know that diabetes, we can screen for it. Again, you are in one of the best countries in the world. This is many ways you can screen for this test accordingly, and a lot of medications that you can do to improve, to treat diabetes and so on. And then of course, cholesterol, smoking, cholesterol, diabetes, high blood pressure. And there's one thing that you cannot change, which is genes. You can't change the genes, but you can alter, you can manage that blood pressure, you can manage the diabetes, you can stop smoking, you can control them, you can reduce that alcohol, because all of those and so on can contribute to to erectile dysfunction. Now, and having said that, not only erectile dysfunction can help preventing you getting blockage to the heart, causing a heart attack, and can prevent you from getting blockage to the brain, causing a stroke. And I've always I tell my student, I said, what do you think is the herald? If you have a patient comes to you, the patient will come to you for erectile dysfunction. Say, oh boy, I'm so happy you're here. Because now you have the opportunity to tell them, you know what? If you don't listen, you don't do something about this, your goal that you're here for is to get this thing working. That's good news. We're going to work. But I know that if we're going to get this thing, not just getting the quick fix, the lovely drug that we call sildenafil or the fancy Cialis or Viagra down there. Not just those magic bullets, but those magic bullets. I don't obviously this is obviously recorded, but I'm an emergency room doctor. I can tell you for sure I can't name anything, but I've had patients whom clearly they took the medication, the lovely Cialis, and the same night they took the medication, within 30 minutes of taking the medication, boom, they died.
Yeah.
So it happens all the time because there's already blockage in the heart.
Mm-hmm. Mm-hmm.
You didn't fix it. You just want a quick fix. You ask your doctor, give me this. Well, ask your doctor, what is the common cause? If you ask me, you said, what is causing ED? I will tell you organic. Organic means multiple issues. Think of them, big of them, multiple issues, and big of them is your cholesterol. Are you building plaque in the blood flow? Are you managing your blood sugar? Are you stopping smoking? Are you drinking alcohol? And then of course I will do certain tests like testosterone and look at other issues. But the key, most important is, have I checked your sugars? Have I been more aggressive to control your diabetes and so on? And I'm glad actually you brought up this question, because really one of the key things that we face within our community is not just, but you've noticed that folks will not normally come to you about preventive care, but they'll come to you to fix that part. And that's the opportunity that we have to fire them up with preventive care. We said, I'm glad you're here, and I can't give you that magic bullet yet. We have to work on your health. This can work this way if you follow a pathway, because otherwise you give them that magic bullet, they're not going to live that long. You just say them death sentence. Okay, the big thing is flow, 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 flow. What is causing the flow? Blockage of those blood vessels. What is causing the blockage? Did you control that diabetes? Did you control that blood pressure? And one of the key things that I notice over and over in the emergency department is, you come into the doctor say you have high blood pressure, and the doctor gave you the pills for the blood pressure. You take the medication. You never followed up. You're taking the blood pressure and your blood pressure is still high. There's something we call in medicine target blood pressure. If you're taking blood pressure medication, your blood pressure is still high, it's like you're taking sugar pills because you have not targeted your blood pressure to the targeted rates that will help prevent problems. So by taking the blood pressure, you got to make sure you get to make sure your blood pressure is at target. It's controlling what you're doing. That is why you have different dosages. The dose may need to be increased. The doctor may need to add another medication to what you're taking to get your blood pressure to target. Without those being controlled, it's like just so many things that it can, and this is one of the key huge issues within our community, just lack of follow-up and so on. And of course, not just the compliance issues. The compliance issues is one, but lack of follow-up. So a lot of folks will comply, but they don't follow up. They say, oh no, you know what? Oh, doc, it always happens like whenever I come to the doctor, my blood pressure goes up. That's a typical scenario. So what does the doctor ask me? Whenever I get to see you, my blood pressure goes up, or when I go home, my blood pressure is fine. Well, the blood pressure machines at home actually have a different value than what we use in the hospital settings. They're completely two different values. So what may be normal for you at home may not be the same, for us, for example, in the hospital settings. And then the other different thing is that, if you're not sure if your blood pressure is fluctuating, you need to get something we call ambulatory blood pressure monitoring. So they can monitor your blood pressure continuously for 24 hours for you to determine for sure, really. So that's one thing I have to say about ED. ED is manageable quite, really, but you got to have to detect the root of the problem. The root of the problem to detect erectile dysfunction. Yeah.
So the solution is not going for the Viagra. The solution is see your doctor first.
Very good. The solution is that look, the funny thing there's again, yes, the two major causes, organic versus what we call psychogenic. The word psychogenic is a no-brainer. Well, you know what? I have this erectile dysfunction, but only sometimes. Sometimes when, but when I watch something, I'm okay. It's only sometimes when you're close to me, that's when I get this thing. That's psychogenic. That's easy. That's easy to detect because it's normal. Every early morning, it's normal for folks to go up. That's just normal. If that's happening, but when I'm only with this person, hey, things are not happening. That's psychogenic. You need counseling. You need counseling for that. but otherwise, yes, the flow. Yes.
Yeah, we'll have two questions, and then we'll go back, and then we'll come back for the shorter session. This question says, can you please, how can Black pregnant women advocate for themselves in the doctor's office since maternal mortality is high in Black women?
Wow, what an excellent question. This is an excellent question. First and foremost thing is that you have to, one of the key things that we have, particularly from where we're coming from in the part of the world, we used to doctors telling us what to do. We used to, doctors is the commanding feature. What the doctor says, that's it. That's where we're coming from in the part of the world in Africa. Medicine in Canada is completely different. You are the boss, not the doctor. Medicine in Canada is patient-centered, not physician-centered. It's patient-centered. The doctor is scared at you that if he messed up with you, you can complain to the college. We know that we have certain rules. Look, we listen to you. We are excellent, good listeners, and we only do what you want. You see, if a doctor that's commanding you, he's not practicing medicine in Canada. You don't last long. You don't last long. Medicine in Canada is patient-centered. They listen to you. That's a very, very important thing. Now, so say, for example, in terms of, now there's a lot of issues why maternal mortality, for example, will occur. A lot of other factors that occur there, as we just named some of them. We talked about some of the multiple factors that we talked about in terms of some of those risk factors. Things like pre-existing diabetes or for example, maternal age, for example, if you're old enough and so on, before you start to have your babies and so on. And there's a whole lot of issues that compile to that. So we can't just sort of put into the, but, the bottom line is that when you see your doctor, and I can tell you for sure that having been practicing medicine in Canada for over 20 years, it's very unlikely for a physician not to listen to you. It doesn't mean that you don't have, there's always bad apples in anything, there are always bad apples, and I can't tell you that as a physician myself, I have not seen, particularly as an image doc, I haven't seen areas that can improve. I've seen a lot of areas that I think, hey, racially this could improve. In terms of, in a way, yes, that always happens, no matter what we are. But, clearly, going across the border, I can tell you for sure, even when I go to New York, there's one time I went to New York in sort of a New Year, I kind of looked and I said, oh boy, man, I'm so scared that I'm going to be stopped or something of the sort, but, we hidden here, in terms of what can we do? So when you remember that you advocate for your health, that's the key thing. You got to realize that, let the doctor know that it's your health. And, screening tests are screening tests, and that is why I said it's completely different. For example, when you're pregnant in Canada, you follow rules, you follow through, you have your antenatal record. You see your doctor, for example, a particular period of time in the first half, every month, once a month. And then in the second half later on, you see them almost every 2 weeks after 28 weeks. And then at about 36 weeks, you see them almost every week. You see your doctor every week. Your doctor monitors you throughout. If they mess up anything, something goes wrong when you see them, they know they're in trouble. Yeah. And you have to advocate for yourself. And one of the key things that I noticed within our community, and this, I'm so glad that this discussion was asked, One of the key things that I notice is that, it happens to me all the time. I can, my family members would tell me, why don't you call the doctor and talk to the doctor? They're afraid. He said, why don't you call the doctor yourself? Maybe the doctor will listen to you. I said, no. Do you just tell the doctor? Do you just talk to the doctor? Tell the doctor what is wrong with you, and tell the doctor what, and you have the right to read about your information. You have the right to read, for example, and you have the right to ask, friends and family. And I can tell you for sure that, I'm more than willing, if you have a burning health question that is bugging you and so on, suddenly, I'm sure Melissa, probably one of your congregations and so on, is one of my students and so on. Clearly you can, I will share my contact information. So you can suddenly, if you have any burning health questions and so on, that you think that, there's an issue and so on, I can suddenly, give you a little bit of advice. But I can tell you that, doctors in Canada, majority of doctors in Canada, again, I'm saying majority because a whole lot of them and so on practice patient-centered medicine. And the College of Family Physicians encourages that. And part of the evaluation, all the exam centers or any part of exams in Canada that you write is that patient-centered. That authoritative figure, it's a no-brainer. No, that doesn't work in Canada. You are the boss, they will listen to you. And in terms of, as I said, maternal mortality, there's a whole lot of issues. And that's significantly improving even among our own community. But remember, there's so much other social issues that needs to improve, that certainly contribute to all those issues and so on that we have to deal with as a community, which obviously we hope that in the long term, this will obviously improve. It's sad enough that we're still hearing some of these notorious bad stories from our own countries, for example, where we are coming from, where the rate of maternal mortality, particularly, is even, it's so bad, just terrible. It's just completely unacceptable. And yet, what an excellent question. Thank you so much. You've asked that question.
Yes.
That was good.
That's amazing. Before we go on break, let's take this question as well. If someone is pregnant and they have fibroids, can the fibroids be taken out during a C-section or delivery time?
Excellent question. Now, as you know, of course, that it all depends on where your fibroids are. One of the key things is that, when you have fibroids and you particularly, and this is one of the key things, if you have fibroids, it's very important thing that particularly if you're thinking about getting pregnant first, it depends on where your fibroids are located. Remember, the baby is going to be inside the womb. If you have fibroids that are located there, they're going to disturb the baby as the baby grows. So they may need to be removed even before the pregnancy by a procedure called a myomectomy. If the fibroids are also bigger fibroids that are outside the uterus, outside the womb, that's going to put pressure. They may also need to be removed because as the baby grows, they may put pressure on the baby. But to answer your question, when you are pregnant and you're hoping that, when at the time during labor, should you just remove my fibroids? Well, those are two different procedures. Okay. When you having your baby during labor, the incision that's going to be done is not the same, for example, that they're going to be doing laparoscopically to go in for those fibroids. And that's a time of, you are in a position where you are so happy looking to get your baby, and that baby came out from a C-section, getting this, and then you're going to go to another longer procedure and so on. So legally, it's something that you can discuss with your gynecologist, but that's not something usually that is suggested at all. Particularly, of course, you may say, why not do one incision? You're there already. Why not just get those guys out? It sounds like much more easy, to just say, I'll just get those guys. But the site where you're going for the incision is completely different in terms of sites where, again, it all depends on where your fibroids are, but that becomes more trauma, to the uterus and so on. So, again, as I said, that's something that you should discuss with your own, specialist and so on that will take care of the baby at that time, but it's not something that's commonly done.
That's excellent question. Yeah. We're going to go for our last break. We'll come for a very short time. I know you have a lot of questions. First come, first serve. And then we'll talk about preventative medicine after 40 for a short time. And then we will let you go. Stay tuned. We'll be back in a second. Well, welcome back. Welcome back. It's getting more and more interesting, but our time is almost up. We're going to talk about preventing diseases and sicknesses after the age of 40. What should we do, those of us who are young now, after 40 years, to prevent sicknesses and diseases?
Okay, well, this is one of the the greatest topic ever, because one of the as you know, of course, as I've been doing so far with this series, is you ask yourself, what is the most common cause of death at this age? What will kill us as we start to get older? I won't say older though. I would use the word younger, just like you said, as we're getting younger after the age of 40. Now, there are two major important issues. One of them is cancer. Cancer actually kills a lot in Canada than even heart attacks. So one of the key things, so you see, so cancer and then heart attacks. So cancer, then heart attacks. So when you hit 40, you're going to think, boy, what are the things that I can do to prevent cancer? And what do we have for preventive care in the setting of cancer? And what do we have for preventive care in terms of heart disease? So if we start about think of cancers, let us, so because of that, again, there's something we call the Canadian Task Force for Preventive Medicine. But apart from that, your family doctors are well equipped and well trained in this. And also the government does, remember, we have our coverage. All of us have OHIP coverage, those of us who are in Ontario. And we know the fanciest things behind this, behind having the coverage. It's better for the government, it's better for taxpayers to screen you for disease, prevent you from getting cancer, than the millions of dollars they will spend in trying to treat your cancer, and then you still don't add nothing to society. But by then figuring out your cancer, pick it up earlier, prevent it, and then you can still continue to work and money, and then of course take care of your family and live longer. So hence, of course, cancer prevention is one of the most notorious things that you think about once you hit the age above 40. Mainly, we tend to hit, say, 50 and above. But the reason why we use the word 40 is because that's when you can unify a lot of changes. So let's start with cancers first. Now, for us, one of the key most notorious issues that you think about, when you start about thinking about cancer, you're going to start from the whole body. Where can you get cancer? Well, the one that a lot of folks tend to be worried about, of course, which we don't tend to worry, we can still get something called melanoma. Melanoma is skin cancer. We think that because we have our pigment, so therefore we have less melanoma. Of course,
we melanoma.
Yeah, we are lucky, so we have less risk of getting melanoma. But you have to remember that, it all depends. We have black folks, we have different kind of skin colors. You have black folks that have mixed race. You have black folks that are, that are really cool. And that's one of the key things, because again, you forgot the fact that your skin color is lighter. And then of course that you still have to protect yourself accordingly. And then of course, and when you get born yourself to those salons, also tanning and so on, you go on, and then you tend to see that mole. It's rare, but when you see that skin lesion, get it checked and get it dealt with. Ask the doctor to tell you whether that needs to be biopsied or not, because it's so important to prevent it than anything else. Now, when we're going to hear about the common ones, the common one is thinking about in terms of lung cancer. Well, again, we're talking about those cigarettes. Those lovely cigarettes, for example, we're talking about over and over. If you think about smoking and cancers, you can name them. Just try to say, okay, which cancer that smoking doesn't cause. It's better to say that.
Right.
Than to say, so just think. Once you hit 40, think. That cigarettes that you've taken, that tobacco that you take, remember that tobacco, and then that when you breathe that big tobacco can give you oral cancer, So you sort of think about those issues in terms of, and we have actually this a whole of a category of certain, sort of black folks that chew tobacco. And then of course they end up with squamous cell carcinoma, for example, of the oral cavity, and that can be quite nasty. By the time they don't see a doctor of those, they think it's probably a tongue infection, something usually,
And then late, then they have to lose their tongue. They have to lose a whole lot of things and so on based on the cancers. So, cigarettes obviously will be something to really, really consider to stop. Now, talk to your family doctor if you think that you are thinking about quitting. Your doctor always will screen you for those, and this is simply thing that he can do. The funniest part is that people change when they end up getting the problems. I've seen a lot of patients tell me, you know what, I stopped smoking a year ago. Oh, congrats. He said, yeah, as soon as I got the heart attack, I stopped smoking. You wait until you got a heart attack. You wait until you got a heart attack before you stop smoking. So this is the same thing. Don't wait until you get a lung cancer before you stop smoking. Don't wait until you're diagnosed with that particular cancer, for example, before you stop smoking. So that's one thing and so on. Now, we have, let us say, simplest thing that it can easily prevent, for example. Well, sometimes the food that we eat can cause problem. Of course, eating a lot of fat, less fiber, can cause so much bulk can occur, and then it's a risk of certain cancers. One of them is colon cancer. And colon cancer is something that, as I've seen a lot in a lot of Black folks, I've had very close calls with close folks near me that has colon cancer. Now, and again, and here's one of the key issues. Just imagine when you turn 50, what happens? As soon as you turn 50, you notice that a mail, the ministry will send you a mail that you have to see with some cards because they wanted to check your stool samples.
That's right.
And that's called a FIT testing, or fecal occult blood testing. And what we're doing with those testing, we're screening for blood, that you don't see in your naked eyes. So you take your stool samples, and if we see blood in the lab that you don't see in your naked eyes, so that you can go to the doctor and get a colonoscopy, because the colonoscopy can see precancerous cells, things like we call them polyps. Polyps are benign growth, but some of them can be pre-malignant. So the idea is that when you get your colonoscopy, the surgeon can remove that polyp that could have turned cancer 2 years, 3 years down the road. They remove it. And so that was so-called a polypectomy with a simple procedure than waiting until you get colon cancer. So by doing that simple test, but I can tell you for sure that when you get those things in the mail, what will happen? They just dash them out. No. Am I going to put my poop into that slide? No way, man. You just look at that. But that's a huge preventive care. The other thing is that, it's differs. Say, for example, if you have a family history, if you have a father who had colon cancer, you don't need to do that FIT test. You may need the colonoscopy. You need to get a colonoscopy, not that test. That FIT test, that paper test is just for screening. I can give you a very good example. For example, a few weeks ago, I had a patient who comes in because he thinks that he had hemorrhoid. He's 59 years of age. He said he had a hemorrhoid. And then I look at him. Yes, he had a hemorrhoid. But I told him this. I said, you're over the age of 50. Hemorrhoid alone is not enough. You having blood, you see in your stool, you need a colonoscopy. You can't say you have a hemorrhoid because you can see you need a colonoscopy. After the age of 50, you must, even when you see blood in your stool, irrespective you have a hemorrhoid or not, if you see blood in your stool, you need a colonoscopy. That's no brainer. Just imagine when you turn 50, we send you those paper things, those FIT testing or those fecal occult blood because you never saw blood. We want to see if we can see it microscopically. But if you already poop, you see blood in your poop, you need a scope. No brainer. But this man went along for 3 years thinking that he has hemorrhoids. And then I sent him for scope. He had late stage colon cancer. So one of the key things, hemorrhoids are just veins. It could be the cancer that's pushing them down. So if you're over the age of 50, clearly you see blood in your stool, you need to see a doctor. They need to look through. A colonoscopy means they scope the colon. They put a light to look at the colon. And if they find anything, biopsy, they can biopsy it. They can remove the polyps that can later cause cancer. It's master of preventive care. It's something that we see all the time. If you notice, for example, another very key important issues that you tend to see, we're talking about cancers. Our lovely women, in the past, we used to say after the age of 50, 50 years and above, as soon as you turn 50, bam, you get a letter for mammogram. And again, not just from your family doctor, you get a reminder, because public health is so intensified in this country. You get a reminder, and they're going to remind you almost every 2 or 3 years for you to go back for your mammogram. And if, for example, you fail, you're going to get reminder letters. Because they know that if you get that benign lesion that you can see in your mammogram, they can remove that lesion in a mammogram early before it turns cancer. You prevent disease. So screening, it's a very important thing that we should follow up, and we should make sure that we get that time to go do them. Because you can easily, and that's one of the major issues that we face within our communities. We don't follow screening times. We can get the opportunities to get screening times, we don't follow. And I'll just share one thing about pap smears, for example. Our young women, usually, of course, we don't bother women getting pap smears until they are, at least for Ontario, after the age of 21. But with Canada-wide, usually 25 years and above. Pap smear is like a small, tiny thing that they take, a small swab that they take through the neck of the womb, the cervix. And there's something we call cervical cancer. Cancer is the cervix. The cervix is the neck of the womb. So when you go to your doctor will take that small sample through the cervix, or the neck of the womb, and send it to the lab to look for abnormal cells. Because if you have any abnormal cells, they can treat them to prevent you from getting cancer of the cervix. This is why, because pap smears have been done so well, that we see the risk of seeing cancer of the cervix is low in Canada, because of our screening methods that we have. Because we can pre-treat all those abnormal cells, we call them dysplasia, or those abnormal cervical cells, for example, which is one of the notorious care behind family physicians. And now, if your pap smears are all normal, you just have to go see the doctor once every 3 years. You don't have to get them every year. As long as they've been normal, every 3 years you go get your pap smears, for example, to make sure that as long as they remain normal. But those pap smears are very important to ensure that you can see those abnormal cells and you can get treated. They get treated to prevent you from getting cervical cancer. Now, those are just a few things that I'm sort of naming over down there. But by far, we're talking about one very key point that he just raised. We said cancer. We're talking about breast cancer and the mammogram. But it differs. You don't have to wait to age 50. If you have a sister, you have a mom who was diagnosed with breast cancer when they were 50, when they're diagnosed with breast cancer when they are 45, you don't have to wait until somebody call you. Tell your doctor that my sister had breast cancer when they were 45. You need to get your test done 10 years earlier. You don't wait. You don't wait. Just like a colonoscopy. If you have a brother who was diagnosed at 55, you're not going to wait until you are 50 before you get a colonoscopy. You're going to get your colonoscopy much more earlier. When an illness runs in your family, you got to tell your doctor, can I be screened for this? It runs in my family. It does help a lot when you tell your doctor so they can do the test quite early. But you just said one of the big thing is that, what about the other killer? We said cancer, the other killer. And things like prostate cancer, I'm not even going to prostate cancer. I'll leave that alone because, although it's preventive care touching prostate cancer, a few, it's very common within our community, but some of them really not so lethal per se. But I want to spend time a little bit talking about heart attacks and heart disease.
Okay. Doctor,
yes.
Before we go to heart attacks,
Mm-hmm.
when you mention advocacy for our own health, somebody's asking this question, that in most doctors' office, they have a signage that says you can discuss one issue per visit. And they're asking why so? And wouldn't that stop the patient from discussing all that is going on in their body? And, that may directly affect the doctor's diagnosis, even if the symptoms may seem unrelated?
Right, very good question. Now, well, things have changed. There's actually something we call periodic review in family medicine. Now, in the past, we used to call it annual physical. I have to go to the doctor for my annual. The doctor will get paid a lot more for that annual because they spend a lot of time with you. In the annual physical, that's when he talked about these things, the preventive care. In the annual physical. Now, to answer the question, for example, if you come to me for sore throat, and the family doctor is only paid us a little bit of a amount of money to take care of your sore throat, and then you want to talk about preventive care with that sore throat, he may tell you know what, only issue, let me just deal with the sore throat and so on. But you have to realize the fact that you have the chance to tell the doctor, can I book for an annual review, periodic review?
Okay.
Ask for annual periodic review, and they get paid a lot for that. You know, they get paid almost 2 times or 3 times more than what they get paid for that small visit that you go for, because they have to do that thorough review, and that they're going to focus on those preventive issues. And that's what it should request for. It should request for that annual review.
So
and
you should request it yourself.
Oh yes, your family doctor should do that, because most family doctors, it all depends, obviously. There's a lot of ways that family doctors get paid through HIP coverage and so on. But, it's clearly lucrative for them to do an annual physical, which is obviously, and the government encourages that because they want to make sure that preventive care is sort of done. But because, you don't necessarily have to see somebody every year, but doing that periodic review, you may see a patient that you have to, that's why they changed it. Before we used to say annual physical, but now we call it periodic review. And then when you get to your patient, really you have to ensure that you utilize this screening test accordingly. And these are the things that I'm talking about. For example, once you hit 50, you're a woman, you get a mammogram. You can get it earlier if there's a family history. You're going to get a FIT test or fecal occult blood or colonoscopy or when you hit 50. You can get it earlier if there's significant history, for example. Those are all routine testing that are done, but they only be done clearly if you see your doctor, if you have a doctor. And yes, if you have a doctor that doesn't really go through screening, you have to advocate for yourself. You have to tell them that, yes, I need to do my annual periodic review because I need to talk to you about certain things and so on, preventive care. Of course, the doctor will be intrigued. Yes, of course, remember, it's patient-centered. We listen to you. You just have to say, and we listen to you, because we know if we don't listen, we can get serious problems, not just with our college, who gives us license and so on. But as physicians, we all have huge egos. We want to make sure that you are happy because we know you are a client.
That's amazing. After he finishes with the heart, I'm going to give you the chance to ask 2 more questions, and then we'll release him. He's done an amazing job. So, doctor, about the heart.
Right. So all I want to say is in terms of thinking about the whole picture of what we call atherosclerosis. In other words, things that leads to blockage. Think of it. What happens when people get stroke? What causes stroke? Well, it's basically decreased blood flow to the brain. Decreased blood flow to the brain. What causes a heart attack? Decreased blood flow to the heart. Just think of it in terms of, because if the heart muscles need to pump. But but they also have blood vessels that flow to the heart for the heart to be able to pump. If you get a plaque built up in those blood vessels, they block the flow to the muscles of the heart. Your heart dies. It can't pump. So here you go. You woke up in the morning, dead. That's the most common why you'll have sudden death. You woke up dead in the morning because heart attacks occur early in the morning. You just have the plaque that you built up in the blood vessel of the heart. You build up over years. You didn't get it treated. One day it just ruptured, it just flop, and then it blocked the muscles of the heart completely. It decreased the blood flow to the heart muscles. Your heart muscles stop, and then you're dead. Now we know that stroke kills a whole lot of folks. And if you ask me, Doc, what is the most common cause of stroke? I can tell you for sure. Is it preventable? I said yes. How is it preventable? Blood pressure. And it's sad when in the emergency department, I have a gentleman that I saw recently, a Ghanaian actually, in the emergency department. He came in just recently in the March, and he was in the March for an ankle sprain. His blood pressure was extremely elevated, because we check vital signs. And then I look at him, I said, brother, and one of the key things that I love emergency medicine too, it's kind of fun in the past, because I take every patient, whether this is my father or my mom or my brother or sister. So it's kind of cool in terms of the way we deal with patients. And, most of the time, patients goes very well with the flow. The only place that doesn't go with the flow is if you work at Toronto General, Toronto Western, where I worked for 6 years. Those folks don't like you call them brother. But if you go rural Canada, rural Canada, of course, or our folks in Milton or Oakville, for example. No, those folks are nice. But look, black folks, of course, I call them brother and sister. They love it. It's kind of usually fun and so on. It's the communication. When I said, brother, I said, you know what? You've got an ankle sprain, but I don't care. I really don't worry about your ankle sprain. I'm not worried about your ankle sprain. I said, look, I may not see you next month. I may not see you a year from down the road. And he said, why? Because you'll be dead. Wow. I said, why? Because you have high blood pressure. You're doing nothing about it. And I asked him, I said, have you ever been diagnosed with high blood pressure? He said, yes. He said, when was that? Oh, 4 years ago. Did the doctor put me on? Yeah, he put me on medication. How long, were you taking them? I only take them when I check my blood pressure. If it's high, I take them. That was his response. And this is very common around our community. Remember what I said earlier on. If blood pressure, it's the blood vessel. Remember that blood vessel, that blood flow goes through that tube. That's where that blood flow goes. When you have high blood pressure, that tube narrows. The blood flow doesn't go through. It doesn't go through. It doesn't go through. And then one day, what happens? It just bursts. You bleed. You get what we call a hemorrhagic stroke. You bleed in your brain. Either you paralyzed, people will be waiting for you until you die, or you don't get paralyzed, or you have what we call an ischemic stroke. You just basically cut off the flow. Now, of course, things have changed with management. We have advanced care that we can utilize, but we don't have that much to do if you have a bleeding stroke. Even in the advanced world, if you have a hemorrhagic stroke, we watch you die peacefully. Why should that happen when you can do one thing, check your blood pressure? And the one thing that I can leave everybody here in terms of, please, when you are over the age of 40, check your blood, even that, at least even when you're young, you should get your blood pressure checked once, particularly we in our community, after the age of 25, I recommend that get your blood pressure checked once. If it's fine after 25, when you wait, after 40, start checking it much more regularly, but if there's hypertension runs in your family, you got to get it checked much more earlier. So the things to do, blood pressure can literally, controlling the blood pressure saves so much life within our community. But the fact is that we're still doing a very poor job. And remember, taking a pill for blood pressure is not enough. Ask yourself, is my blood pressure at target? At target. And when I say at target, what may be good for myself may be different from what may be good for pastor. Because I may have diabetes. Because I have diabetes, my target is different from the other person who has high blood pressure that does not have diabetes. So you need to know where your target, and you have to work with your doctor. Because if you say, oh, you know what, my blood pressure is not so bad, it's just 150/90, it's not so bad. But that's high. It's not so bad because you have high blood pressure. So you still continue to take your medications. Instead of talking to your doctor to increase the dose, to get it to target, you continue to take those pills and then boom, you stroke. So the major issues is to think about what can I do to try to help yourself and so on, to prevent those and so on. Hypertension is one thing that you can really do something about. The other thing is that, there are certain screening tests that you do, which is part of your annual physical. Your annual, which we don't use, again, I don't use the word annual physical, we call it periodic health exam, which you get, we call it periodic because you can go in to see your doctor when you think that's necessary to get that exam, for example, if you haven't gone for a while. And that exam could include your cholesterol. And the doctor will look at your bad cholesterol, your good cholesterol, and he can talk to you ways and means to improve them. And again, it's all individualized depending on your risk factors. What may be normal cholesterol for me may not be normal for the diabetic. It's all different. We're all different in terms of our risk factors. But cholesterol, the reason why I'm saying cholesterol, I keep on saying cigarettes, I keep on saying high blood pressure, I keep on saying diabetes. I'm not even talking about family history, because if you ask every other black man has a family history of somebody with a stroke or heart disease. so let's not talk about family history. Let's talk about, smoking. The things that cause you to build a plaque, the cigarettes. The high blood pressure, do you manage it? Because the cigarette causes the plaque to build up. The blood pressure causes things to slow. The blood doesn't flow very well. All of those are culprits for plaque to build up. And diabetes notoriously increases the risk of plaque built up. When you have diabetes, you almost like a ticket of any time. You don't know when the time is going to come. So you got to be aggressive on controlling that.
Wow.
Okay, I'll leave you guys with
That's
that.
amazing. And I think we learned so much. I said I'm going to write a book. I'm joking about this, but I've learned a lot. I've learned a lot. Doctor, guess what your first question is? It's about the COVID vaccine. Person says, will a person that takes the COVID vaccine be guaranteed that they'll be safe from catching this COVID again, or they are guaranteed from infecting another person? Is there a guarantee?
Right. Very, very good question. Now, first of all, if you look at this COVID vaccine, these are newer vaccines, these RNA vaccines, they're quite new. And, when you look at the efficacy, it's 95%. That's very good. Particularly, we're talking about the Pfizer vaccine, the one that we have right now in Canada. It's 95% efficacy. Now, and when we talk about efficacy, if you look at it in terms of, think of it, if you get the disease, the chances that the disease will not be severe, that's what we're talking about. You can still get a disease if you get it, but it's not going to be as severe if you do get it. So that's what you want to look at. You want to look at the efficacy. How good is that? So when you just look at it, yes, there are a few people within the study that had the disease, but it's not severe. The disease is not severe enough, and so on, when you have the vaccine. So that's one of the good things. It's very effective. Remember, think of it. COVID-19. Look, I'm an image doc. The other day I did a shift. It's amazing. I can tell you for sure. At least I have 4 COVID patients. And it's sad in terms of we seeing these patients out there. When you probably seen those that are getting better. We are seeing those that are the extremes. COVID-19 is not an easy virus, folks. This virus kills. It does kill. And if you think that because you're young, your immune system is very strong and so on, you got to think about, what about your father, who has diabetes? What about your own grandparents? There's a whole lot of things that you think about in terms of, not just in terms of thinking about, even yourself as a person, even if you get it, say for example, you get a disease. If you get the worst form of it, now you recover, but then you have complications in the future, and complications can be anything, for example, and complications include things like that could literally cause you to have blood clots. There's a whole lot of things that we don't even know yet that are going to occur. What we know for the vaccine now, we know that the vaccine itself is safe at least for 3 months based on the studies. That we know that very, very well. We know the safety profile for that. So if we know that this thing is safe for 3 months, we know that. We don't have long-term studies yet in terms of follow-up, but we know that it's efficacious. It's 95%, particularly it's for severe disease. Now, even if you get COVID, it's not going to be severe if you have the vaccine. That's the good part about the vaccine itself. In terms of, there's a whole lot of questions, even ourselves as physicians, of course, we are going to be the first group that are going to get the vaccine. And I can tell you for sure that as soon as I'm calling to get my vaccine within the next couple of weeks, I'll be the first person to go down there and get my vaccine. Not only because I'm worried that, if I do get, because look, if I do get COVID, I know that I can easily die from COVID because I've seen it. But I know that if I take the vaccine, the likelihood I'm going to die is less. It's efficacious. I know that the side effect that I could get, well, the injection site is going to hurt a little bit. I get a flu shot. I just got my flu shot about 3 weeks ago. It hurt. Well, maybe I may get tired. I may have to say I'm not going to work tomorrow because those folks who already got the vaccine in England, some of the side effect is fatigue. You get so much tired that you have to call in the next day. So if I have to get the vaccine, I have to get ready. Maybe tomorrow I may not be able to do my shift if I get too tired from getting the vaccine. But I'll be the first person to get the vaccine because I know it's efficacious. And I know that RNA vaccines, the good thing about them is that our body has lovely cells that we call the killer cells, our immune system defenders. So you give me that vaccine, we know that the vaccine has, once you get the first vaccine, in about 10 to 12 days, you have 50% protection already within the first vaccine. When you get the second vaccine 3 weeks later, after a week after the second shot, you get like 95% protection. Based on the antibody titers and so on that are done. So I look at that study. Just about last week I was looking at the New England Journal of Medicine. I look at that study for the Pfizer vaccine word for word. word for word. Of course, I'm an educator. So I look at that vaccine word for word in terms of the studies that were done. Yes, it's only about 8% of black folks that are involved in the study. 8% of black folks. I look at, I'm a black man. I look at, hey, can this vaccine work for a black man? So I just look at that. It was a black man in the study, So you look at that in terms of, I look at all those stuff in terms of and so on. So, and I look at the efficacy. I look at, of course, there's a lot of Caucasians that are involved, over 80% Caucasians, but you have different ethnicities. And of course, it works among the black folks that took the vaccine. One of the key, and every information is available. You have to think that we're in countries that, and even today, for example, was linked through the news and so on. We are so much protected. Even, for example, you end up getting side effect from the vaccine. The government will protect you accordingly. For example, if you get something that's bad come up later on, for example, there will be some funds that will protect you and so on. So, look, is the vaccine safe? Is it efficacious? It's efficacious in the terms of it prevents severe disease. Now, in terms of asymptomatic phase, that's not part of, you can get that in the studies. And there's some areas in the studies that I don't want to get into those details of those small, tiny niche in the studies areas. Because what I'm really interested in is how efficacious. And when you say efficacious, if I take this shot, first of all, what's my chance of getting COVID? It's less. It's less effective. If I get COVID, is it am I going to die from it? No, it's less likely I'm going to. But what about if I get COVID without the vaccine? Well, you never know. I'm gambling. I could either go to the extreme and then, So you got to weigh, but as a clinician, I don't only think about myself. So it's a completely different scenario. I think about if I get COVID and I have no symptoms with COVID, and then I pass it on to my lovely patient that I see. And then due to my own negligence, killing somebody. So there's a part of me that says, look, I have patients that I take care of, that no matter what, irrespective of what I think about myself, I'm definitely going to take the vaccine. But again, having said that, it's efficacious. The evidence is out there, but we don't have long-term evidence, folks. We don't have things beyond 3 months. We don't know in terms of the side effect behind that. But what we know so far, it is efficacious, okay?
Amazing. Now, I know that we have audience on YouTube, some on Facebook, but for those of you at Zoom, I'm going to give you an opportunity to ask a question. And so if you have a question at Zoom, tell the moderator that you want to ask a question. I want to give you that opportunity so that all of us can hear you ask your question. If you're on Zoom and you have a question, tell moderator, I want to ask a question. And then we can hear you. Now, doctor, this question says that normally children have earwax buildup in their ears.
Mm-hmm.
What causes that, and what is the natural remedy or treatment for it?
A very good question. Now, first of all, to be straightforward, that earwax is not something bad at all. Earwax, if you have earwax in your ear, they defend you against infection. So when you're having them, it's not bad. The problem is that when they start to cause you problems, that it becomes an issue, right? They're good. They're part of the defense mechanism for infections. The ear canal itself, you can see the ear canal is a tube that connects the outer part of the ear to the middle ear. And the ear canal itself can have those fancy wax in them and so on, which is most of the time, most of the patients I've seen, it's usually genetic predisposed. Some folks are just predisposed because it runs in their family in terms of building up those wax. Sometimes it's hormonal changes that cause those small, tiny wax to build up. But I tell you for sure, it's a normal process and they're very good. They actually defend you against infection. Now, the big problem that you get is that when you start to go dig at them, when they do nothing, putting those Q-tips in those kids' ears, that actually can traumatize the ear canal. Then you remove that cerumen that has that defense that protects the kid's ear. And then the kid end up developing what we call otitis externa. That means inflammation or infection of that ear, which we also call swimmer's ear, by the way, in a way, because you traumatize the ear canal, and that trauma causes a small tiny bacteria to build up, and that starts to cause the kid to get pain. So the wax itself was okay until mama drill it up with a Q-tip, So wow. The only time, should you bother much about wax? No, unless if it does affect hearing. So one of the key things is that if you have a child build up wax, and then there's so much, all of things, people talked about this, during candling and using mineral oil that you can put over down there to break it down. There's other things over the counter, things like Serumenex or Serumol. These are all ear drops that you can put in the canal. And these ear drops will help just crack it down, open up the passage. They're much more better than you having to put stuff in the ear and trying to Q-tip the ears. I will not recommend that at all in terms of traumatize the ear canal. Now, sometimes, what you notice will happen with earwax is because the wax built up so much that the kids stop hearing from the ear. And then, of course, when you get to see the family doctor will note that the patient has trouble hearing. And then, of course, then what they will do, the family doctor we have a whole lot of weapons that we can utilize. And thus we have small, tiny ear curette that we can utilize to look at the ear. If your kid has an earache, don't just presume it's because of the wax, because they could have an infection. And of course, we will then look into that and so on, and then solve the problem. I will not encourage at all going at those wax. Going at them tend to cause more damage than not. It's actually helpful to have wax in the ear because it's actually defend against those bacteria that you can have in the ear canal. Okay.
It's rather defense. That's amazing. Now we go back to the Zoom folk with us. If you have a question on Zoom, now you can ask the question. If not, Zoom, do you have your question? All right. Nobody has indicated they have a question, so I'll go with the other questions as well.
The doctor spoke very well.
Okay, we are listening. Who was asking the question? All right. So Tech is going to allow.
Saying that the doctor answered most of our questions in his lecture, so we are really grateful.
Well, he is a professor, an assistant professor. He knows how to teach. He has thoroughly taught us, giving us a lot of information to work with. This is amazing, and I know for sure that we will want to have him back. If he's willing to come back to us, we'll be so glad to have him again, because there are a lot of things we have to learn, a lot of things we have to know and understand in our community. But the last question will be this: Doctor, should I only see my doctor when I'm sick, or sometimes I should just go and do these periodic checkups? That'll be the last question.
Excellent question, and that's a very good way to end the session. Yes, of course, that's exactly what we're talking about, the periodic health review. It's very important to do a periodic health review. You should see your doctor not just when you're sick, and that's exactly when you're limited, because when you're sick, you go with a chief complaint, and the doctor is going to try to address that chief complaint. But when you go in a periodic health review, your doctor is going to review you as a person, and that's initially they're going to get that full thorough history and so on about yourself, and get to know a little bit about you, your family history, so that they can screen appropriately, do this cholesterol test. Remember, blood pressure, you don't get a headache, you don't get nothing, you just one day get a stroke. Some folks are lucky. Some of you guys are so lucky that you come to the emerge with a headache and then your blood pressure is high. We'll figure you out. Or maybe you showed up with a cut and then we see your blood pressure is high. You got to see the doctor. You don't wait until you're sick. That's so much important, so that's how the doctor can do this periodic review, screen for this illness, most of these things that we're talking about to help prevent disease. And remember, it is free and you are clearly in the best country in the world, for preventive care.
What a way to end this session. Oh, thank you so much, Dr. John Cabell, for such an amazing time. This is Family Life. Was somebody speaking?
Yes, there are 2 questions on Zoom.
Okay, ask them for me quickly, all of them, both of them.
Okay, the first one says, just a minute, I'm going there to read it. The first one says, how do you prevent cholesterol? The second goes, what causes stomach bloating and how to prevent it?
Okay.
Okay, two excellent questions. Now let's talk about the one first in terms of what prevents cholesterol. Now, as you know, of course, that's one of the key most important thing in the formation of plaque is cholesterol, right? That's the key thing. That's what causes your blood vessels to form plaque in them. And it's all about what you eat. You are what you eat. Remember that thing? You are what you eat. So you need to ensure that not only that you are what you eat, but also you are also what you do. Thinking about your diet, and all of us have different kind of diets that we eat, but there's certain foods that are high in cholesterol. There's a whole lot of things in terms of we saying, look, how much can you eat, for example, total cholesterol, or how much of it should be, saturated fat. You have to reduce your saturated fat to significantly low. So what I would recommend is this. We all eat different kind of foods. There's no food that is bad. I can say that quite clearly, but the quantity. And of course, and particularly for those of us who already have an illness, so you already have high cholesterol. It's very important that you get to see a dietitian. And dietitians, and one of the key things I love about Canada is that they work with you. You have a dietitian that works with your culture. You can ask a dietitian that actually would work with you with your food. If, for example, cellular diet, they can work with you. They can say, you know what, palm oil is a no-no because it can raise your cholesterol up. They know the foods that you eat. They walk you right through. So yes, there's a lot of dietary issues that can be restricted and limited. And of course, increased activity will also help reduce your cholesterol. Okay. Now, I'm not going to go into those details because we all eat different kind of food and so on. But yet, and the other thing that you can look at, if you go through Google, you put in cholesterol diet, it's not going to match what you eat. Because, the folks who wrote Google, for example, maybe somebody, depending on the food that they eat, it's not the kind of food that you eat. So therefore, you will not catch up very well. So clearly, a dietitian, and we all have dietitian locally. I can tell you for sure, actually, I met with a dietitian about a few years back. And this dietitian is from Sri Lanka. And it turned out to be Sri Lankans and Sri Lankans eat almost similar food. So we're talking, it was quick. We were talking to Shannon called Bamba, and it's amazing how much foods that I actually figured out right away in terms of, yes, where the problem was, in terms of what I actually eat. So excellent question. Yes, it's all what we eat that build up that cholesterol. And I can tell you one thing, there's something we call bad cholesterol versus good cholesterol. You want to get the good one good. Because the good cholesterol, the function of the good cholesterol is to take all the bad cholesterol back to the liver so the liver can clear it out. The liver can say, bad cholesterol, go out. That's the function of the good cholesterol. And that's what we call HDL. So when you ask your doctor, he said, what is my HDL? HDL means high density lipoprotein, HDL. That's the good cholesterol. You want to get that number up.
And is there any food that can give you a lot of good cholesterol?
By the way, if you look at the evidence, things like a simpler one that I can come with, I don't drink alcohol, but I can tell you also red wine has been well studied to increase good cholesterol. I'm not saying go get red wine too, but a little bit of red wine can actually increase good cholesterol. It can increase good cholesterol, but other things that can increase good cholesterol is exercise. Activity, for example, you can get your good cholesterol up. It's amazing, for example, how much of us genetically predisposed to good cholesterol. But I just give you a classic example about how exercise and red wine will be one of those key ones and so on. Again, if you do drink wine, a glass of red wine, clearly, you know that there's some benefit to it in terms of raising your good cholesterol. Now, the other key thing that I want to, now, so that HDL number needs to go up. Maybe you need to boost a little bit of your activity and so on. Most of us tend to be quite sedentary, and it might be a good thing if you don't go to the gym, get something at home. That's a good time to get your daddy, or to get your young grandparent. Will be the good time to get a young grandparent and a treadmill. For Christmas is coming up. That's a good time to get a treadmill at home. To help them moving, because that will actually, obviously improve, good cholesterol. Now, but the one that you really have to deal with is the bad cholesterol, and that's why we're talking about all this diet. The bad cholesterol is what we call the LDL, the low one, the low density is the bad one. LDL, bad cholesterol, low density lipoprotein. What that guy does, that's the one that blocks the blood vessels. It's the one that, and that's what your doctor has to target. Your doctor targets that LDL. Ask your doctor, what is my LDL? What is my target? You know, everybody has their own target. For example, if you're diabetic, your target has to go almost below less than 2 for that LDL. And you need to control it. That means your sugars, that means your doctor may have to increase your cholesterol medication dosage. Otherwise, you're taking a sugar pill. You know, so these are all things that targets. What is my target? What is my target goal here? Always ask your doctor, what is my target blood pressure? What is my target cholesterol? And know the bad versus the good. Where do I go? And the doctors will communicate to you when you want to. You know, they will listen to you. But if they quickly realize the fact that you're this kind of patient that you just want to hear from them what they tell you. Hey, doctor, just take this pill. You're just going to take this pill. Take this pill. No, stop and ask, why am I taking this pill for? We are very quick to give pills, but why? And when you give me the pill, are you monitoring my pill that I'm taking? Am I getting the right dosage? Otherwise, I'm just as well taking, I better as well take a sugar pill. Waste money for nothing, despite all this pill, I end up with a stroke. Got to talk for yourself. You have to advocate. And by advocating, you ask questions, just like the way you're asking me these questions right now. Now, with regards to bloating, there's so many causes of bloating. You know, as of course, as an educator, and apart from that, as an emergency room doctor, you know, when you say bloating to me, it means a whole lot of things. You know, many things that can cause bloating. You know, it's something we call, is it acute bloating or is it chronic bloating? You know, in other words, is this something that happens all of a sudden? You get bloated, you know, or this has been going on for a longer period of time. You know, or is this related to diet? You know, there's so many questions that you have to ask. You know, some people, particularly Africans, we're predisposed to lactose intolerance. Thereby, when malabsorption, when you eat certain milk product or something, we don't have the enzymes to break down the product. And sometimes we'll be bloated. You know, you just bloating after you eat anything that has a milk product or because you don't have the enzyme to break down the lactate. Because you have, and then of course you bloat because then you don't absorb. It becomes to get more gassy. You know, when you eat anything, for example, when you don't have the enzymes to break them. But there are also a whole lot of things. One of the key things that I have to say, when you feel bloated, ask yourself, what are the other symptoms that I get with this bloating? Because bloating can just be a head herring of something sinister. You could be bloated because you have some other problems, you know, that are occurring within your body that contribute to the bloating. And I don't want to name a few. There's so many things that can cause bloating. It's just so many of them. The key thing that you ask yourself, hey, am I just bloated after I eat something, certain foods? Could be something, the most common one that we suffer a lot as, as black folks and so on, because of the tendency for us to have lactose intolerance. Is it that's what we're having? Is it because you're having bad reflux? Do you get heartburn indigestion with it? You know, is it because you have an ulcer? You know, there's a whole lot of things and so on that comes into play, you know, or is it because you have a blockade? Ask yourself, is it acute or is it all the time? Is it chronic? It's something that's been an ongoing issues. And then clearly, you know, you definitely almost certainly need to see a doctor. Don't presume that this is just benign. If it's bugging your life, anything that disturbs your life, remember, you have the right to see your doctor. Your doctor will take a good history, a thorough history, and perform a very focused physical examination to try to figure out the many different causes of bloating. And then order any test that is necessary to make the diagnosis. Don't just presume it. Don't just take gases and stop. You know, that may be disastrous sometimes, particularly if it's acute. If it just happens suddenly, you could miss something quite serious.
Wow. Thank you, Dr. John Cabo. What a night to remember. We have taken in a lot. We're going to digest on it. But I want you to share this with somebody. I want you to be the eye of somebody, make somebody aware, direct them to the video, let them watch for themselves. They will learn a lot. This can prevent something bad happening to somebody. This is good information. We are so honored to have you. And we really, really desire that one day you'll come back and talk to us again. But thank you. And all of you who join us, whether on Facebook or on YouTube, or those of you who are on Zoom, we are honored to have you as guests. Thank you. and have a wonderful evening.
Thank you for having
Thank you,
me.
doctor. Thank you.
Bye-bye.
I'm not the hair clipper. No. No.